Welcome back, everybody. David here again with Med School Bootcamp. So in this chapter, we're going to talk about cystic kidney diseases. And the main ones we're going to highlight here include autosomal dominant polycystic kidney disease, autosomal recessive polycystic kidney disease, and autosomal dominant tubulointerstitial kidney disease. Say that 5 times fast. So if you all are ready, then off we go. So in this first video, we're going to talk about autosomal dominant polycystic kidney disease. Sometimes this is abbreviated to ADPKD, so be familiar with that as well. So what is a polycystic kidney disease? Well, it is a development of cysts in the nephron themselves. And so at the microscopic level, we might see a normal healthy nephron that looks something like this. But in a cystic nephron, right, we have these little outpouchings that develop. And again, this is microscopically, but then if you draw your attention over here macroscopically, we see a normal healthy kidney, fairly smooth on the outside. But a polycystic kidney is going to have a bunch of cysts. It's going to look a bit enlarged. It's going to have a lot of irregularities. And you can also see it here on a gross specimen that a lot of these things that I'm circling are actually cysts within the kidney themselves. So that's what a cystic kidney disease is. In our first one, we're going to talk about the pathophysiology of autosomal dominant polycystic kidney disease. And you guessed it, this is an autosomal dominant condition. What does that mean? That means that patients just need one of the genes from their parents to get the condition, right? Versus autosomal recessive, you need both of the affected genes to actually show the condition. This is due to a mutation in PKD1 on chromosome 16 or PKD2 on chromosome 4. These are, unfortunately, nitty-gritty details that they like you to know for the exam at this level. And so really the best memory aid I can offer for this is that 2 and 4, right? 2 times 2 equals 4. You can make that association, PKD2 and chromosome 4. And then for PKD1, I just remember that there's a 1 in the 16, so I make that connection right there. So just kind of a little bit of a memory aid to hopefully get you through test day. Now, this is going to do what to the kidney? It's going to lead to a development of numerous cysts in the renal cortex in the medulla, and we're going to get bilaterally enlarged kidneys. So instead of nice, smooth, small kidneys right here, we're going to get large cystic kidneys that we see over here. And I don't think it's super high yield for you to really understand the biochemical pathways here, but essentially these genetic mutations right here affect cilia-mediated signaling pathways in the kidney itself, which ultimately leads to cyst formation. Now, what happens once the cysts actually begin to form and develop? How does this present in a patient? Well, typically this is going to present in an adult. So sometimes autosomal dominant, the AD, is actually also called the adult polycystic kidney disease. So it can be AD for autosomal dominant or AD for adult. And this is an important compare and contrast because I'm saying that this presents in adults, so kidneys appear normal at birth. However, this is the opposite of autosomal recessive polycystic kidney disease, in which this would actually present in children in utero oftentimes. So autosomal dominant is the adult version, and autosomal recessive is more typically the child's version. And that's a really good distinction to make for board-style questions. That's not always how it presents in the real world, but for board-style questions, that's a pretty good delineating feature to differentiate. Are we talking about autosomal recessive versus autosomal dominant? What's the age group of the patient that we're talking about? Now, these patients can also present with flank pain, hematuria, hypertension, urinary tract infections, and eventually renal failure. Why is this? Well, as these cysts develop, they take up space. They compress things around the system, right? This can actually create the enlarged kidney, which can cause flank pain for a patient. If you have an enlarging mass in your abdomen or in your retroperitoneal space, this can cause some pain for the patient. This can also cause hematuria because these cysts can actually rupture. And so if this cyst actually ruptures, right, and contents leak out, this can actually lead to blood in the urine or hematuria. Additionally, hypertension, right? We can get compression of the renal vasculature. Think about it, right? As these cysts get bigger and bigger and bigger and bigger and start to grow outwards from the kidney, it should make sense that this can compress the vasculature both around the kidney and within the kidney itself. And so compression of the vasculature leads to less blood flow to the kidney. What's that going to do? What do we always talk about? When the blood flow to the kidney decreases or the kidney thinks the blood flow is decreasing, what's going to happen? That's right, activation of the RAS system. That's going to bring back more sodium, bring back more fluid, and voila, we have hypertension. Now, why a urinary tract infection? This is due to stasis. Again, these cysts can develop and cause compression, and this can decrease our fluid flow through the nephron itself, right? Typically, fluid goes out here, and the act of urinating through the body keeps bacteria from allowing it to ascend into the urinary system. But if we have stasis in the kidneys, right, a cyst is compressing our forward flow of fluid. That's going to create more opportunity for stasis to occur, for fluid to not flow quite as readily, and that gives bacteria the opportunity to ascend the urinary tract system. And finally, if these things are not resolved, right, ultimately these patients can progress to renal failure. This can get progressively worse and worse and worse. We would expect to see typical renal failure labs like increased creatinine, uremia, and volume overload. Now, some associated findings with autosomal dominant polycystic kidney disease. Really important here. We have liver cysts. This is the most common one that I want you to know. The reason is because I've seen questions where they will give you a presentation of a patient who has autosomal polycystic kidney disease, but they won't tell you about the kidneys explicitly. That makes the question too easy. Too many people will get that correctly. Instead, they'll tell you about the liver. They'll tell you about the cystic liver that's going on. They'll tell you about the family members who also had a cystic liver. This patient has flank pain. They have hypertension along with a bunch of cysts on their liver in addition to a family history. This is again pointing to autosomal dominant polycystic kidney disease, and that's why I'm highlighting it here. If they want to be tricky, they'll talk about the liver cyst. They might also talk about the pancreas cyst. So this is a multicystic disease, right? It's not just the kidneys that are involved. Pancreas can get involved. Liver can get involved. And you can also see intracranial aneurysms. This is another tricky way they'll ask about it. They'll talk about a patient who had a ruptured aneurysm in their brain. Oh, and they'll also mention their mother had the same thing happen. Their mother's mother had the same thing happen. Again, what's the connection here? What's going on here? We have 3 generations of people who have had intracranial aneurysms. This is likely pointing to an autosomal dominant condition. So keep polycystic kidney disease in mind, not just on nephrology questions, not just on kidney questions, but if you see some of these other findings, liver cyst, pancreas cyst, or intracranial aneurysms. Because if you do keep that in mind, you can get those tricky questions right on test day. Finally, a couple less commonly tested ones include mitral valve prolapse and diverticulosis. Again, this is a multi-system disease. Now, thinking about the diagnostics here, these are going to make sense to you really easily. Ultrasound, what's going to happen? Bilaterally enlarged kidneys with multiple cysts of varying sizes. Why? Because it's called polycystic kidney disease. Key point here, varying sizes. Why do I say that's a key point? Because that's a differentiating factor from autosomal recessive polycystic kidney disease. When we talk about the ultrasound findings of autosomal recessive, we typically say the cysts are of the same size. Is this always the case? No. But classically, we say that varying sizes for autosomal dominant versus equal size for autosomal recessive. Again, that's 2 key points here where we can differentiate autosomal dominant versus autosomal recessive. Now, additionally, if the ultrasound is unclear, you can consider a CT, but it's not first line. You can also consider genetic testing. Again, this is not routinely done. If a patient has these signs and symptoms, they want to know if there's a family history, they can get it done. But more or less, we don't use genetic testing necessarily to make the diagnosis for a patient. Now, how do we manage this condition? We have to know, what are we offering these patients? Well, we're going to do symptom management more or less. We're going to include ACE inhibitors, angiotensin receptor blockers for their hypertension and to slow the progression of their proteinuria and their progression to end-stage renal disease. We talked about this in our RAS system video. We talked about this in our ACE inhibitors and our angiotensin receptor blocker video, how these actually work, right? They can be used for hypertension and they are nephroprotective medications, and they would be useful for these patients. We can also consider something called tolvaptan, which through various mechanisms is known to slow the growth of renal cysts. Again, does this fix the problem? No, it's symptom management. We're slowing the progression of the disease. Tolvaptan is a selective vasopressin 2 receptor antagonist. Remember, vasopressin 2, the receptor, are typically located on the collecting duct in the kidney. This is going to lead to ADH inhibition and decrease our water reabsorption. But keep in mind, that's not necessarily why we're giving it to these patients. That is a mechanism that it works. However, the main reason we're giving it to these patients is to slow the growth of renal cysts. If patients have severe end-stage renal disease, we have to always consider dialysis, and keep in mind the only curative option here is to do a transplant. So everything else we're doing is what's called symptom management. So we've sort of already talked about it, but a classic vignette here, just to give you a full picture, is going to be something along the lines of a 40-year-old patient who presents to the emergency department with changes in their mental status. They are found on workup to have an intracranial aneurysm that has ruptured. Now, on past medical history, you find out that the father also had a history of intracranial aneurysms in their 40s, and you think to yourself, this is kind of a young age to have multiple people with intracranial aneurysms. Is there a genetic component going on? The answer is yes. The question may or may not give you any information about their kidney status, but you know that autosomal dominant polycystic kidney disease is not just involved the kidneys itself. We talked about the liver cyst, we talked about the pancreas cyst, and the intracranial aneurysms. So this is a way they can present a question to you that is not giving you the most obvious clues, right? They're not saying a 40-year-old patient presents to ED with high blood pressure, you get an ultrasound and you find there's bilateral cystic changes in their kidneys, they're enlarged, and you know right away it's autosomal dominant polycystic kidney disease. That's too simple, that's too straightforward. Could they do that? Sure. More likely, they're going to give you one of these other options to choose from. And this is where you're going to really be able to shine on test day. So quick summary of this video, autosomal dominant polycystic kidney disease. AD for autosomal dominant or AD for adult. Either way, this is a genetic mutation, an autosomal dominant genetic mutation. Presentation is going to include flank pain, typically in adults. You get flank pain because the cysts get really enlarged. That's painful. We think about kidneys appearing normal at birth. Why? Because this is a contrast with autosomal recessive, which typically occurs earlier in life. We're going to see some other things, associated findings I think are almost more important here than knowing the kidney stuff, because that's how commonly it's tested. Liver cyst, pancreas cyst, intracranial aneurysms, mitral valve prolapse, diverticulosis. This is a multi-system pathology. Now, diagnosis, really just need to know about the ultrasound here. Unlikely they're going to test you on these other ones, but they kind of make sense intuitively. Like, sure, we can get a better image if needed. Sure, we could get genetic testing if needed. Now, when it comes to management here, it's mostly symptom management. That's what all of this stuff is right here. Only curative treatment option is to get the renal transplant because this is a genetic condition.